Okay, I'm going to get us started in the interest of time because we have a lot to go over this afternoon. So good afternoon, everyone, and thank you for joining us today. I'm going to go ahead and get started. It's my pleasure to welcome you to our second of three webinars. Today's webinar is about keep working till we beat melanoma, the operation and science behind TIL therapy. Before we begin, I want to share a few reminders. Please join the Zoom question and answer to ask any questions. They will be answered towards the end of the webinar. You can utilize the vote function within this section to move questions up in the queue. Please don't put any questions for the faculty in the chat. This video will be available to view via the ONS webpage in the coming days, as well as via HOPA's YouTube channel. For HOPA viewers looking to claim the all-important CE credit, please make sure to write down the unique CE code at the end of the session in order to submit for CE credit in HOPA Learn. And this course should already be available on your dashboard within the HOPA Learn website. None of the planners or faculty for this activity have any relevant financial relationships with ineligible companies to disclose. And for the Oncology Nursing Society, it is accredited as a provider for nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Learners who view the full webinar and complete the online evaluation will earn 1.0 NCPD contact hours. And the link to the evaluation will be provided in the chat at the conclusion of the webinar. The evaluation will be live for 2 weeks following today's program. This webinar is being provided jointly by ONS and HOPA. I'm so excited for our panelists today. Suppose I should probably take a second and introduce myself as your moderator, which I failed to do, first job of a moderator. So my name is Zahra Mahmoudjafari. I'm a pharmacy manager at the University of Kansas. I'm really looking forward to introducing today's panelists, Patricia Chambers, Dr. Jennifer Collins, Andrea Fadel, and Amanda Pawlenty. Just as a brief background, so Patricia is a nurse educator at Moffitt Cancer Center in Tampa, Florida, with experience working with commercial and investigational products in the cell therapy unit. Welcome, Patricia. Dr. Collins practices an oncology clinical pharmacy specialist in cell therapy and hematology at the University of Chicago. Andrea is a transplant and cell therapy nurse coordinator at the University of Chicago Medicine. Welcome as well. And then last but certainly not least, Amanda Pawlenty is a senior clinical manager for inpatient hemonc BMT pharmacy practice at Mayo Clinic in Rochester. So I will hand it over to our wonderful panelists and we'll see you back for the panel discussions.
Thanks, Zahra. Hey everyone, I'm Jen. I'll get us started. Here are our disclosures for this presentation, and then we can jump right in. So some objectives for today are to explain the mechanism of action in the FDA approval of tumor-infiltrating lymphocyte therapy, or TIL therapy. We are going to kind of breeze through this since it's already been touched on in some webinars, but we do want to include it for completion's sake. We're going to spend a lot of time summarizing the workflow of treating a patient with TIL therapy, as well as compare best practices for safe administration of interleukin-2, since I think that's what everyone's most interested in today's webinar, and then identify common barriers to implementing a TILS program at your institution. So the FDA approval for, the only FDA-approved product we have right now is called lifileucel, which is a tumor-derived autologous T-cell immunotherapy. Got a mouthful there, but is indicated for the treatment of adult patients with unresectable or metastatic melanoma. These patients would have had to have been treated with a PD-1 inhibitor, and if BRAF V600 positive, would had to have received a BRAF inhibitor. This indication was approved under accelerated approval based on the objective response rate. So it is contingent, it's a continued approval is contingent upon verification of this benefit in further trials. So this brings us to our first question is how many of your institutions are administering TIL therapy, either commercially or on study protocols? All righty, it looks like most of the attendees here are not currently administering TIL therapy. Some are participating in the clinical trials and a few are using commercial therapy. So hopefully this is all helpful for you all who are trying to start using this at your center. So what are tumor-infiltrating lymphocytes and how do they work? They are exactly what they sound like. They are your immune system's natural response to a tumor. So these are lymphocytes that have been smart enough to migrate from the blood to attack the tumor cell. And basically what we do is just we're isolating these T cells that were smart enough to get into the tumor by resecting them from the tumor tissue. In the lab, they're activated, expanded, and then reinfused back into the patient after some lymphodepleting chemotherapy. It's FDA-approved in unresectable metastatic melanoma, which you touched on, but there are ongoing studies in many other solid tumor spaces, including lung cancer, colorectal, gynecologic, etc. The trial that kind of led to approval of lifileucel was conducted in adults with metastatic or unresectable melanoma, good performance status, as with all clinical trials, and were treated with what I mentioned is the FDA approval, at least one prior therapy with PD-1 inhibitor and BRAF inhibitor if positive. So the primary endpoint was overall response rate, and then secondary endpoints are listed there. There were a few cohorts to study kind of how best to roll out this project. So first, there was a non-cryopreserved product. Cohort 2, which is where we get majority of our info from, is the second generation cryopreserved lifileucel, which is typically how we prep our cell therapies. Cohort 3 is lifileucel retreatment, and then cohort 4 is cryopreserved lifileucel second generation. So response rate, overall response rate is 31%, which if you're not familiar with melanoma might seem a little underwhelming, but just to put it in perspective, historically, these patients' response rates were 5 to 10%. What's really notable about this therapy is actually the duration of response. So even though only about a third of patients respond, this is one, much higher than historically available for these patients, but two, the duration of response was not reached. So in those that do respond, it does produce a lasting response. Overall survival for the whole cohort was 14 months, and progression-free survival, again, for the full cohort was 4 months. And I will hand it off to Andrea to go over kind of workflow and patient timing.
Thank you. So let's start off with the workflow. And it kind of starts off on a bit of a joke where the insurance approval looks like it's just one small little rung. As we know, that's not the case. So with the insurance approval, since this is such a new therapy, we are utilizing those single case agreements. So this is a bit of a longer process. Currently, we hope that as this becomes more common, more popular, that we can get away from that. The next important part, of course, is slot allocation. The number of slots available for a manufacturer is determined by the FDA, and then the manufacturer further allocates these slots to hospitals. And this can be the trickiest part sometimes. Once you finally get that insurance approval, now you have to get that slot for your patient. Once we have that slot, we're ready to go for the tumor excision, which is the surgical resection of the tumor and that naturally infiltrating lymphocytes. I would say between this and the slot allocation, some of the tricky parts are just making sure you have that slot. That also works for the surgery team and that the room's available as well. From there, the sample is shipped off to Iovance for the product prep, where it's isolated, enriched, and expanded in vitro at the manufacturing plant. That's then preserved in DMSO and shipped back to the hospital. Turnaround time is approximately 1 month as they continue to grow and develop. There might be a little bit of growing pains where it's slower some months, but we hope to see it faster overall in the future. Once those cells are shipped and received at the hospital, we can start that lymphodepletion process utilizing fludarabine and high-dose cyclophosphamide. Per the package insert, it does start 7 days prior to cell infusion, but some sites are doing both the cyclophosphamide and fludarabine on the same days for a 5-day start. There, we get day 0 with the cell infusion. We do want to pre-medicate with Tylenol and Benadryl, and then do a quick IV infusion. And then after that is the fun time, the high-dose IL-2. So this amplifies the activity of the TILs, but has a lot of potential side effects, which necessitates an inpatient hospitalization for these patients. For this patient journey, so I love this slide because it does show how that insurance approval looks several weeks. First thing, of course, is we have those patients identified as potential candidates. They have imaging proving that they are going to be a good candidate, and they're willing to move forward after hearing about all the IL-2 side effects. From there, we do want them to meet with the surgeon to discuss collection and set up the collection date. What we try to do at our institution is have that first visit the same day as the visit with the surgeon, or the testing at the same day as the visit with the surgeon, to try to minimize trips for patients who might be traveling quite far. Step 3 is that TIL testing to ensure the patient is clinically appropriate to go forward. This could be additional imaging if it's not recent, including brain MRIs or head CTs. We're thinking echoes, EKGs to look at the heart, kidney, liver labs, infectious disease markers, and potentially pulmonary function tests as well. Next, we get that surgery for tissue collection. And then, like it says there, that last step is that starting the LD chemo after the TIL cells are manufactured, confirmed in spec, and delivered. And that within spec is really important and key. So what does the lymphodepleting chemotherapy schedule look like? Day -7 and day -5 are the high-dose cyclophosphamide at 60 milligrams per kilogram plus mesna both days and fluids. And then day -5, 4, 3, 2, 1 are going to be fludarabine at 25 milligrams per meter squared. Day 0 is the TIL infusion. And these, of course, can be reduced based on patient characteristics. And then we get into the IL-2. So the IL-2 is a high dose at 600,000 units per kilograms. It can be given either every 8 hours or every 12 hours for up to 6 doses, and you can start anywhere between 3 to 24 hours after those TIL cells are infused. And this is something that your institution will have to determine which time works best for them. You can potentially delay and or omit doses depending on the patient's clinical status, which is why we recommend a clearance checklist before each dose. And another important feature is that we are going to initiate daily GCSF starting day +1. I'm going to pass it over to Amanda.
Thanks, Andrea. So next we'll talk a little bit more specifics about the IL-2 and the lymphodepleting chemotherapy. So lymphodepleting chemotherapy, for those of you who have partaken in CAR T, might be familiar with this term. Essentially, it is the cyclophosphamide and the fludarabine that is used to deplete all of the immunosuppressive or other regulatory cells within the system to help improve the ability for those TIL cells to expand, function, and persist and provide the benefit that we're looking for with this TIL therapy. So we've already discussed the dosing. Broadly, the mechanisms are probably less important in the role of the individual chemo, but the bigger function is really that sense of depleting kind of our current immune system. As far as the side effects for these chemotherapy agents, they're going to be similar to what you see using this in other hematology BMT patients. The cyclophosphamide is an alkylating agent, so we get myelosuppression, we get some of those GI symptoms like nausea, vomiting. We can get cardiotoxicity, and then we're using that mesna in conjunction with the cyclophosphamide to prevent the toxicity of that hemorrhagic cystitis along with fluids. Fludarabine can also induce myelosuppression, which again is part of the goal with these chemotherapy agents. We also see the GI toxicities, pulmonary toxicities, and neurotoxicity as possible as well. So important pieces, but the toxicities tend to be pretty similar to when you're giving them in other circumstances for patients as well. The interleukin-2 or IL-2 is probably the one that most of you are least familiar with. It used to be used more in treatment, but has been pretty outdated in a lot of disease states and has kind of come back with TIL therapy now, especially at this high dose. So aldesleukin or Proleukin, which is the brand name, is a human recombinant interleukin-2 product. So often you'll hear it just referred to as interleukin-2 or IL-2, which is what we'll call it the rest of the presentation. So the goal of this drug is to promote the proliferation, differentiation, and recruitment of T, B, and those natural killer cells, so your immune system. But in a TIL setting specifically, it's actually meant to help stimulate those TIL cells to enhance the efficacy of therapy. So that is the thought of why this TIL therapy was studied with the addition of IL-2 to kind of boost the impact of the TIL cells. We already talked about the dosing and frequency. The pre-meds, as mentioned, they can be nausea and vomiting inducing, so we will pair it with an antiemetic as well as Tylenol to prevent fevers with that infusion. Some of the big side effects we want to talk about, we'll talk about the most common ones and then some of the most severe ones. So when we think about common side effects, often are related to hypotension, edema, so a lot of fluid shifting, including dyspnea that can include pleural effusions. There are GI symptoms associated with this, as well as decreased in your counts. So we can see thrombocytopenia specifically, but you can see other myelosuppression as well. Some of the chills and dyspnea, tachycardia, fever can be also with the infusion and an increased serum creatinine, so some kidney dysfunction as well. However, most severe, and the reason why this has been administered in the hospital, is the capillary leak syndrome, which ultimately is a major fluid shifting mechanism that results in hypotension, dyspnea, edema, and really end organ damage. That can result in changes in the cardiopulmonary system, CNS toxicity, renal dysfunction, a lot of mechanisms that can impact our other organ function, requiring a lot of other supportive cares, including pressor therapy, procedures to tap for fluids, fluid support. So this is really close monitoring is necessary for that severe capillary leak syndrome. I will bounce back to Jennifer now to wrap up our study.
All right, so this study, this slide basically shows that all the side effects we used to see in IL-2 therapy, we are still seeing with TIL therapy. So as you can see, almost all the patients, not almost all patients did experience at least one treatment emergent adverse effect, which is anticipated with this kind of dosing of IL-6 or IL-2. They generally were consistent with the underlying disease and also the known safety profiles of IL-2. And it was consistent in all the dosing cohorts, which tells us that it really is the IL-2 that's driving these toxicities, as that dose was consistent amongst the cohorts. So the main ones we've kind of highlighted here are thrombocytopenia, anemia, fever, and febrile neutropenia were the most frequent and significant ones. And then I won't touch on these again. Amanda already mentioned kind of the laundry list of side effects you may see. So this brings us to our second audience response question. What side effects of LD chemo and IL-2 stand out as kind of the most challenging to manage from a nursing perspective? I'm not sure if the poll was working. Sorry, I can't really see if the poll is having responses, but we'll kind of keep the suspense and let Pat speak to her experiences and what have been the most challenging as an inpatient nurse taking care of IL-2 patients. All right, the next question, who is most important when setting a patient up to receive TIL therapy? A, the pharmacist, to ensure that IL-2 is on site and to evaluate all medication orders. B, the physician, to clinically evaluate patient and determine the eligibility. C, the nurse, to educate the patient and help coordinate appointments and logistics. Or D, all of the above. I expect 100% on this one. All right, 100% correct. The answer is D, all of the above. Instituting TIL therapy really is a multidisciplinary team requirement, and so you really cannot implement this therapy if you don't have strong representation from all of the areas. All right, and then we have a few panel discussion questions to go through that Zahra is going to lead us through.
Thanks so much, Jen. I appreciate it. And I really appreciate the background. And I can't agree more with the audience response question that it does take the entire village plus then some. I thought, when we were setting up CAR T services here at my center, I thought that was the most complex thing I'd ever worked on. But then TILs came into the chat. And so I know that all of you have also experienced the same. So I'd love to understand maybe from Andrea or Patricia, any challenges, and both from Amanda and Jen, whoever would like to take this first, challenges that we experience with scheduling patients.
So some of the more challenging things that we may experience with our patients is we know that they're going through the process of the lymphodepleting chemotherapy that was mentioned earlier. And once they're completed with that, they are scheduled in our institution to actually come to an inpatient basis to get their TIL infusion. However, some patients, like we were talking about, may actually experience some of those symptoms that are coming from the high dose cyclophosphamide. So some of the challenges we have is making sure that we have the capacity to be able to move them into an inpatient basis to be able to care for their symptoms at that time. And then once they're actually going from an outpatient basis to an inpatient, obviously we can monitor it. So that's probably one of the biggest challenges that we start from the patient journey from outpatient to inpatient. I know from the other scheduling, I think that Andrea can probably talk a little bit more about it as far as making sure that they have all of the clearance and things. So I'll let her take over from there.
Yes, absolutely. Calendar challenges can be a huge problem, especially when you're first starting off. You might want to start with one or the nurse who is doing the IL-2 only having 1 or 2 patients, which means that we need to also look at the nurse's schedule that day. Other things that might be of consideration is how many patients you have getting IL-2 at once. So if you're starting off and you have a lot of people going at once, that can be really challenging. And so that can sometimes slow things down when you have to limit the number of patients who can admit in a week. I think in general, some things we were able to work out in advance, such as how many patients we could have maximum a week, what days they could admit based on nursing availability for the IL-2. Other things are just a general challenge with the new products, such as availability. We talked about slot allocation. We've been really fortunate to have guaranteed so many slots a month, and we work a couple months in advance with our surgery team and the manufacturer to determine what days those will be for those surgeons. But you can have last minute changes that can be a challenge to get a patient on. Insurance can also be a challenge, especially for this brand new treatment. If it's, there's quite a few insurances out there when it first happened who had never heard of it, and that delayed a few patients right away. Another thing I just want to point out is if a patient is considered out of spec product and we have to recollect them, that can also be a bit of a challenge because we want to do it right away. And is there slot availability? Is surgery available? There's quite a few things that I think have gotten better with time as we work together as a team, both with the manufacturer and with the surgery team, and also our inpatient team as well. But it did take a couple of months to really build those relationships to be a solid point.
Andrea, I think you really covered that very comprehensively. I couldn't think, I was going through my own checklists of how I would respond to that same question. Amanda, I saw you unmute. So do you have anything to add to this question?
Yeah, I think, one question we might tackle later in the panel is, the setting of the IL-2 administration. So at our institution, we require ICU admission as well. So it's not just the coordinating, as Andrew talked about, very succinctly in coordinating the inpatient space, but also the ICU space, which is sometimes uncontrolled of when you can book, claim a bed in advance. But so we really are working to coordinate to kind of block those rooms ahead of time. And so that does limit the number of patients we can kind of have in a week's time. Given that we're relying on our ICU staff to administer and monitor for the IL-2. We also found with our first several patients that we want to give the IL-2 on the weekdays and avoid weekends when possible, just because of the staffing that we have and kind of availability for issues and questions, especially as we were tackling just our first few patients. So we really tried to plan those admissions accordingly and align the cell infusion days to be on, Monday, Tuesday or Wednesday, so that your IL-2s maybe went into Saturday morning, but not kind of into the rest of the weekend. So something we didn't think about up front. And then as we had our first patient, we kind of had this, oh my gosh, moment where we really wanted to shift things around and even just a day or two to make sure you have enough people available to troubleshoot if issues or questions come up, but also so that you're not kind of putting all of these big decisions and kind of the tracking on 1 or 2 people who this is new to everyone. So.
Really, really important points. Cannot agree more. And not only this particular process, not only introduced surgeons into the process, but also in a different way, the ICU team, and a little bit more of an upfront responsibility. Jen, I didn't want to leave you out, just to make sure. Anything else you wanted to add?
No, I think my colleagues covered it pretty thoroughly.
Perfect. Let's go to the next question. All right. So Andrea, You definitely touched on this a couple of times, and we've also experienced it here at my center, but have you seen problems with products not meeting specifications like we appreciated with the initial CAR-T manufacturing? So curious to know, Andrea, since you brought it up, and lob it back to you, how are you handling those at this point?
Absolutely. So this is a really important question because we are seeing a pretty high percentage right now. So I think first thing that's always really important with that out of specification product is that setting up that meeting right away with the manufacturer and the physician to figure out in which way it's out of spec and if it's something we can still proceed with. If it is, barely 1 billion cells, we're going to be recollecting. And luckily the manufacturer has been fantastic about giving us more leeway for a recollect, so it's easier to schedule. And the surgery team as well, once they hear recollect, it feels like both teams will move mountains to get that patient in right away. However, if it is just barely out of spec, like 7.4 billion or something like that, we might decide to move forward. And if you haven't started your TIL program, this is something you want to think about now. You've got two options: the extended access program, which essentially acts like a clinical trial that all of the patients who are out of spec can go on, and something I would highly recommend. Or you can do the single case IND, which is a whole lot of extra paperwork and you need approval from both the FDA and your IRB for each patient. Unfortunately, we've been doing that route, which just leads to extra frustration and anxiety for the patients, not to mention more work for nurses and the physicians and probably the manufacturer as well. But I would say if they are close though, it might be worth it to go that route. And in terms of delays for patients, I did have two patients that were out of spec and collected roughly the same week. One, we did a second collection. One, we did a single case IND. And to be honest, they both got their cells within a week of each other. So it didn't seem to speed up the process anyway.
I think your tips and tricks are really, really important for those centers that are working to onboard. Really important consideration. Patricia, on the other, Jen, you want to respond to this? Or I think Andrea did a really good job with it, honestly. Perfect. We're going to keep moving on.
As a quick thing, I'll just say for all my planners out there, just make sure you're waiting for this designation of an actual viable product before you order the IL-2. I'll touch on the cost of IL-2 in a little bit, but this, like Andrea mentioned, I think we're right now seeing 50% out of spec rates, which is really high. So we learned the hard way just to wait. Don't get too ambitious when ordering the IL-2. Wait till you get this clearance.
Thank you. Bring up a really important point. At least for me at our center, we keep it on par, so it's not an issue. But you're right; that's not something you routinely do. That's something to keep in good consideration. All right, we're going to keep going.
Oh, I just was going to add one more thing. Sorry, Zahra.
Oh yeah, go ahead. Yeah.
I was going to say it. I think with CAR-T, we learned with some of these out of spec, as we talked about initially, and kind of rebridging, and there was a lot of restrictions in what you could rebridge with, and we ran into some of those issues. There's thankfully with TIL, patients really can be getting some of those PD inhibitors right up until they start LD chemo, which buys a little bit of flexibility. However, if they've obviously become refractory to that or stopped responding, it does put us in a pickle. One of our patients had out of spec and unfortunately progressed to the point where TIL really kind of fell off the table, unfortunately, just in that waiting period. So I think that's something to be mindful of, though. You can kind of keep treating them on another melanoma specific therapy up until you start your LD chemo. So if you need to bridge that time, you have some flexibility, and the timeline is a little more flexible compared to maybe what we were seeing in some of the CAR-T studies.
Awesome points. Really appreciate it. All right. So I'd like to take you through helping us understand how do we safely monitor and administer IL-2 at your site, taking into consideration site of care, clearance checklists, any patient-specific considerations.
As Jennifer mentioned, this is probably what most people are interested in. So I will definitely I'll click through slides and let Pat guide through some of the monitoring and things from the nursing perspective. And we can talk about how some of our sites have done this monitoring, but certainly understand there's a lot of flexibility and site-specific considerations you'll have to take into account.
So one of the big things is everybody, I'm coming from a facility that had one established, and of course, we're continuously monitoring it. So if you do not have one, the biggest thing is just truly understanding, the administration and what's required. So we originally talked about some settings where it was required to be in ICU, where our setting is we are already in an inpatient setting. So the patient has already received their TILs. There was a question that came up, for example, like how often are you administering the IL-2? Every institution is different. Ours, for example, would do it every 8 hours, Q8 hours. So there's also that time frame of from the standpoint of when they get their TILs and their first IL-2. So the main thing that happens at the minute they're admitted into the hospital, we're basically going to head and have continuous cardiac monitoring. And then we have established vitals where we're focusing on that every 4 hours. And then we're covering everything that you would normally do through your vitals. And then on top of that, monitoring every 8 hours for mental status changes. The eyes and nose are probably the biggest things to obviously continue to monitor, as well as labs, because we were talking about those serious side effects before that, talked about fluid overload and so forth and pulmonary issues. So we're continuously monitoring their daily weights, monitoring for any type of changes. And then if it is required for ICU monitoring, what is that established process that you have? So I'll talk about our institution in just a moment. But then when you think about an overall assessment, we're doing that every single time we go to see the patient. But now we're really focusing on everything that we know that has been proven to be a true risk as far as side effects. So if we're monitoring, any type of bilirubin or creatinine levels, we're monitoring any type of changes or increases. And then a standard protocol that we would have for nurses at our institution is if we did not identify any toxicities through our assessments, then we know that we can go ahead and proceed with giving that high dose IL-2 dose. And then of course, the entire process starts again. So I mentioned earlier that we were doing it Q8, 2 hours prior to us actually making that decision. If this patient was stable to receive that IL-2 dose, we would start the entire assessment process along with their vitals. And then, of course, if we did identify any type of toxicities, we knew that we had a 2 hour or a little bit more window time to be able to address those toxicities. So that could be anything from supportive care medications, transfusions, procedures, and then, of course, increased monitoring that might be needed. So again, that's going to be determined based on your standards of care for nursing, as well as when the interdisciplinary team would be brought in. So before I talked a little bit about every 4 hours, we would be doing those vitals and monitoring, their oxygen levels. The 8 hours, although you're not technically seeing, let's say, like on a CAR T unit where you're looking for ICANS or I-scores, you still are looking for any type of changes in their neural status that might be for emotional changes or difference in orientation. And again, that strict INOs. One of the standards that we have set as far as protocols, which more and more we'll talk about, is just basically saying during that assessment, did that patient actually have the appropriate amount of urine output to ensure that we're not going to do any type of damage to their kidneys with the IL-2 dose. So we're constantly monitoring their urine output as well as their intake. And then every morning, we're ultimately making sure that all the labs are being reviewed by our interdisciplinary team. And I guess from an overall standpoint, as far as protocols, having that team, knowing what that process is going to be, because for me as a floor nurse, I knew immediately that I had an Amanda. I had a pharmacist that I could turn to. I knew that once that patient had basically passed the protocol per se to say that they were eligible for that IL-2 dose, I had somebody that I would call to go ahead and start manufacturing or making the IL-2 so that we could basically stay on target. And then throughout the entire therapy, we're obviously monitoring for any type of cardiac changes as well. I'm just going to let for the clearance checklist, because this is the criteria that we're obviously looking at for any type of capillary leak syndrome. I was going to let Andrea take over from here, and then I may interject as well as other people.
Absolutely, because one of the things about the IL-2 clearance checklist is that each institution does it a little differently. So we think hearing from different groups will give you a better idea of what you might want to include on your checklist. So this IL-2 clearance checklist is designed to closely monitor for and mitigate toxicities of IL-2, mainly capillary leak syndrome, which can result in end organ toxicity. There's extensive grading from dividing toxicities into relative and absolute criteria. So you're looking at, for observation category, is there any relative criteria? So if there is, you might want to initiate corrective measures, consider delaying or skipping the next IL-2 dose. If there's greater than 3 concurrent relative criteria, you want to initiate corrective measures, of course. Skip the IL-2 dose if it's not corrected within 2 hours of planned administration time, and potentially omit all further IL-2 if not reversible. If there's any absolute criteria, of course, we start with initiating those corrective measures, skipping the IL-2 dose, and omitting all further IL-2 if it is not reversible. So some things that you might want to add to your checklist include cardiac measures, such as sinus tachycardia for greater than 120 for relative criteria, but absolute could be if that's sustained for greater than 2 hours, new AFib, SVT, or other sort of arrhythmias, or any other sort of abnormal values, such as elevated CK troponin or an EKG change showing ischemia. If there's any GI, we are of course doing those strict I's and O's like Patricia mentioned. So we are going to be looking to see what their output is, what's their stool output. And this again could be relative or absolute criteria. We're also going to be monitoring those liver labs as well, such as the AST, ALT, and bilirubin. Hemodynamic, if there's any requirement for vasopressors, that could be a relative criteria. But absolute would be if there's pulmonary edema requiring supplemental oxygen to maintain fluid requirements, or if they're requiring any maximum doses of some of these vasopressors. Yeah. For hemorrhagic, is there any blood in sputum, emesis, or stool? Are there platelets 30 to 50,000? Could be a relative criteria, but absolute would be if there's any frank blood in any sort of excrement. Musculoskeletal, if they have any extremity tightness, this could be a relative criteria, but if they've got paresthesias, it could be absolute. For neurologic, there's the vivid dreams and the emotional lability as compared to baseline. That would be a relative criteria, but absolute could be hallucinations, disorientation, non-reversible mental status changes, or severe or persistent emotional lability as compared to baseline. Pulmonary shortness of breath at rest or rails could be relative, but if they absolute could look like requiring new oxygen, particularly if they're on a 40% O2 mask or if they're intubated. Renal, we are looking at those urine outputs again, as well as the creatinine and bicarb levels, and depending on what the level is, could be relative or absolute. And I will ask Patricia to step in at some point for this, but for the clearance workflow, first thing you need is the nurse to fill out the IL-2 flow sheet at the end of the shift or right before that dose. For our institution, we do it every 12 hours and we have it set so that it would start at, it would be the end of the shift so they could get it infused at 9 a.m. or 9 p.m. Then the nurse would discuss with the APP and physician the patient for that IL-2 clearance via phone at, again, like I was saying, it's 7 and 7, so 8 and 8. And then the APP and physician would communicate the IL-2 decision to the nurse, and then the nurse would call the IV room to discuss dispensing that dose. Patricia, does your workflow look anything like this?
It looks very similar. One of the major things that we do is the interdisciplinary team, they're rounding in the AM. So they're doing all of the workflow piece where we all know that based on, the prior IL-2 dose, current labs, current assessment that was completed by the RN, we feel comfortable that that patient is going to be ready for their next dose. So I don't know if I mentioned, so our IL-2 doses are at 6 a.m., they're at 2 p.m. and then at 10 p.m. So when you think about the timing of those, most of the IL-2 doses are given in the evening or early morning. So the workflow has to be pretty succinct so that the nurses know what their standard protocols are. And then every 2 hours prior, the lab's already done in the AM. We're moving forward for the approval. If I was working during the day, then basically I'm, starting my assessment at noon. And then I have that interdisciplinary team basically working with me throughout the time. But typically what we saw is that interdisciplinary team, they were ultimately providing all the feedback to the nurses and everybody that was needing to know before they left, as well as start in the beginning of the day.
Yeah,
Jennifer, do you have I was going to
sorry.
say, do you want to add to I know this is the workflow that you
Yeah,
guys
so
use.
this is ours here. I just wanted to kind of put out there that this workflow is going to be very institution specific based on the site of care, ICU versus floor, as well as just how your service is designed. So our service, we still have not split cell therapy from transplant. So our providers are typically transplant providers, aka they don't treat solid tumors, they don't use TILs on a daily basis. So they do require a little bit more time to go through that checklist, and we actually made a policy arranging it into a checklist form, so it's very easy for them to utilize as they're most of them are not super comfortable with this kind of therapy. So that's why we did the Q12, just given that our service typically has over 20, usually closer to 25 patients and one provider to cover those. It's really challenging to do the Q8 hour clearance. They are also on the floor. So as we know, everything on the floor takes a little bit longer than the ICU, including pharmacy, being able to prep that order and get it up on time. So we actually don't dispense our orders until that clearance, given the cost of the IL-2. Regarding the checklist that you create too, Andrea actually made the entire checklist ourselves, and then a week later, the national guideline was published. So luckily it was vast majority the same, but for those of you who have not started this yet, there actually is like a very handy guideline that has been published by a national consensus group. So I highly recommend utilizing that as this kind of your standard.
And then this is an example of kind of the workflow at my site. So our patients, like I said, are in the ICU. So the nurse and our advanced practice providers kind of fill out that IL-2 checklist clearance at the end of each shift, kind of prior to each dose. We did just recently split off and have a totally standalone, we call it our cellular molecular bispecific service, a CMB service that includes all our CAR Ts, bispecifics, and now TIL patients. So it's still mostly hematologist run, but when we have TIL patients in, we do pull in one of the melanoma doctors to round and kind of be a part of these discussions. So our nurse and advanced practice providers work closely to kind of assess the patient, as Patricia and Andrea have discussed. They also then discuss formally kind of, okay, we're meeting criteria with the physician, get the physician's approval, and then communicate to the pharmacist that we are going forward and the nurse that we are going forward. We our decision was to actually sign each IL-2 dose in the treatment plan, one dose at a time, as kind of the final, okay, we're good to go, since the hem-onc pharmacist, we are not up in the ICU necessarily when all those decisions are being made. It just depends on the time of day. So that kind of final signature in the treatment plan is kind of our okay to go. So similar to Jennifer, we're not dispensing until that each one dose at a time, essentially, just because of that high cost. So once it is signed, then we are releasing and verifying the orders so that it can be prepped and dispensed back up to the floor for administration. So again, I think both workflows highlight the importance of interdisciplinary communication, very close communication with nursing staff, advanced practice providers, if they're part of your teams, physicians, pharmacy, because there's a lot of ways that things can slip through the cracks. There's a lot of decisions and fine points to be considered. And the checklists are really helpful for very objective data, but there is some subjectivity to some of these decisions as well, especially when you don't have a wide breadth of patient experience to kind of pull back on and say, oh, I've seen this before, it's okay, or no, this is brand new. We've had a variety for the patients who've had IL-2 omitted. It's been a wide variety. We had an NSTEMI. We've had dropped platelets down to single digits. We've had the T-Billy increase. So we've had a really variety. We've had some patients get all six and even have a fever. So it's a really wide breadth of what toxicities can kind of halts the process of the IL-2 administration. So that close communication and not making assumptions, really talking through every step, I think until we get a lot of patients through this and have kind of seen a lot more is really vital to ensuring it's the safest administration practice.
All right, I can jump in on this one since these are some patient-specific considerations that we don't think of until the patient comes in and we start to notice these things. So one of the main ones that we've noticed at our institution is the dosing weight. So as always with clinical trials, you have your picture perfect patients, whereas we see it the real world and realize like, oh, wait a second, do we follow the clinical trial or do we not? And so for IL-2, it is weight-based, and in the clinical trials was based on their actual body weight. However, you may consider using an adjusted body weight in patients that are obese. So this has not been closely studied in the TIL setting quite yet. It's so new, even there's the TIL studies out there, only have a handful of patients. But back when IL-2 was utilized as treatment for melanoma by itself, patients who received an adjusted body weight-based dose compared to actual had less hypotension and less leukopenia compared to those who are based on actual. So especially if you have patients coming in with a few comorbidities and you're just a little worried about how they'll tolerate the IL-2, we have been pretty standardly adjusting to using the adjusted body weight rather than the actual. Another thing to consider is a lot of these patients have seen PD-1 inhibitors before and have developed adrenal insufficiency secondary to that. So they come in on hydrocortisone replacement, and then we are also now basically inducing a very, very high stress situation to their body. This again is controversial and definitely needs to be discussed with the patient's primary physician, but due to the concern for steroids potentially inhibiting TIL therapy, but if they are kind of entering that septic picture, despite holding the IL-2, we may need to consider increasing patients with adrenal insufficiency to their stress doses of hydrocortisone.
Okay, so wow, you guys went through so much great information from a nursing perspective and a couple of different workflows. And I was laughing a little bit to myself because we have a third workflow that isn't represented on the slide. So it just goes to show that everyone can do it a little bit differently. It sounds like we've got some pharmacy logistics that you should be considering for IL-2. So looking at Amanda or Jen, which one would like to start on the pharmacy logistics?
I can just get started, and then I'm sure Amanda will have very different processes for her. So again, just to show how this are things to think through and discuss with your institution. At ours, unfortunately, TIL therapy is very dependent on your budget. It is an incredibly expensive therapy, more expensive than CAR-T. And so your ability to provide this therapy has to be discussed with your financial team. And then specifically within pharmacy, IL-2, incredibly expensive. Each vial is over $6,000. So that's putting you at $12,000 to $18,000 per dose. And when you do the math at our institution for the number that we anticipated, this was going to be an additional $3 to $4 million on the pharmacy budget. My pharmacy cannot handle that budget increase. So we, had to go back to the cell therapy team and discuss how this was going to be billed. At my institution, we are like a smaller nonprofit. And so the cell therapy team has actually been the ones that have been paying for the cell therapy infusions themselves. So we just lumped IL-2 into that bucket. And so it does not go against the pharmacy budget, it goes against the cell therapy budget. So again, every institution is going to do this differently, but it definitely needs to be discussed beforehand because we learned the hard way that this was not finalized before we started taking patients, and the first 3 patients significantly affected our pharmacy budget. Second is your in-house supply and storage. Zahra already kind of mentioned that they just keep a par value, which is probably how I would recommend it. I feel like based on your number of anticipated patients, probably the best way to management. Our pharmacy inventory system is abysmal. It's never correct. Our electronic inventory system is never actually correct. So unfortunately, we are actually doing kind of like patient-specific orders and making sure that we're placing an order for every single patient and checking and making sure that we're keeping an eye on our inventory. Storage, it doesn't need refrigerated, so you have to make sure that if you're having multiple patients, this does lead to quite a few vials. Make sure you have space for them. Waste avoidance. So as I mentioned, it's incredibly expensive. And so you want to make sure that, again, I think Amanda touched on it too, that we're not prepping doses before we are cleared. So every institution does a little differently. Ours just puts the orders on the MAR still, so that the nurse is able to administer once it is cleared, but we utilize the do not dispense function to make sure that it's not generating a charge or we're not making the drug. Amanda's process also works for that, of not even verifying the order until you're cleared. Last kind of just point to touch on before I'll turn over to Amanda is we've had a lot of confusion from the floor nurses as, is this chemotherapy? Does this need to be a chemotherapy nurse? Does it need to be prepared in a hazardous condition? And so I think it's just really important to differentiate the difference between NIOSH hazardous versus chemotherapy in their definitions. So IL-2 is not considered hazardous and therefore does not need to be prepared by a chemotherapy technician. And it will not come up with a chemotherapy sticker or hazardous sticker per them. However, due to the high toxicity, the high cost, it really behaves like a chemotherapy. So we do treat it from a nursing pharmacist standpoint as chemotherapy, that we require an attending physician to sign all of these orders. It requires a first and second check by both the RN and the pharmacist, just as those extra safety measures, given it is so toxic. So just an education point to have with your floor nurses, since that has caused a lot of confusion on our end.
Yeah, I think Jennifer highlighted a lot of the complications and considerations. Similar to Zahra, we keep a PAR level of the IL-2 on site. But it is a big decision and discussion, and it was above my pay grade to make that call. So I was part of the talks, but certainly not the final decision. And yes, we decided to, again, not verify or dispense the label or the dose until a decision was made, but that communication process will look different at every site depending on, with Patricia doing every 8 hours, I applaud them for figuring that out. That was a little bit of a robust undertaking. We do Q12 at our site just to have kind of that time and capacity to handle those on kind of more business hours, or at least hours when we have multiple hem-onc pharmacists and providers on site, kind of versus that 6 a.m. or 10 p.m. when it gets a little tighter. But that waste avoidance and making sure there's a clear path for communication is really important. So, when deciding that, that's really what influenced our decision to do Q12. There is also, this is kind of off this brand, the Q8 versus Q12. I think that's a question that's come up, and the Q12 can help mitigate some of those side effects and toxicities, but a lot of it can be also just built around the logistics and structure of the services and kind of the care hours provided. So it's not Q8 can be done safely and efficiently, as Patricia's site is showing. So it's not necessarily like you're going to get definitely more toxicities doing it every 8 hours. It can be administered that way safely. It just depends on if you have the capacity and threshold to do that at your site. And then, yes, similar, the NIOSH and the chemo definitions was a big discussion with our nursing staff as well. It is kind of interesting because this is all being done for us at our ICU. Our ICU nurses can't even really call down to our floor nurses and our hematology floors for help because they're unfamiliar with the IL-2. So it was kind of a little bit of a gap right when we first started, that our ICU nurses are actually more familiar now with IL-2 administration than our typical CAR T or heme, onc trained nursing staff. But it can be administered by a non-chemo certified nurse. So that is something to consider depending on where you're giving the medication. But certainly, again, we're all supporting the whole team, the whole interdisciplinary team through this process. But pharmacy is a big piece of this just because of the cost of the drug, and something that probably won't be changing anytime soon as more and more of these TILs are approved.
Really appreciate you guys both of you going through the pharmacy logistics that should be considered for IL-2, just like you are. Something also just like Q12, both from a operational workflow standpoint, but also from tolerability from a patient perspective. So appreciate that you bring all those up. You guys do a really great job. We have 7 minutes, so we really want to start and end on time. So we'll go through the last couple of slides, and then we'll have a couple minutes for questions.
All All right, I can just kind of quickly answer this so we can get to some of the audience response questions. TILs with CAR T, we're going to see it more and more disease states, hopefully with lower doses of IL-2 or less doses of IL-2. Hope to see that data come out. Different manufacturing processes. That's kind of where I think we can anticipate to see this. So in summary, basically, TIL therapy is innovative and exciting new treatment, providing a treatment option for patients who really previously did not have any. Logistics, as you've heard, are extensive, multidisciplinary, and include kind of every department you can think of. So planning really does take many, many months. Monitoring for toxicity of IL-2 is extensive, requires close collaboration, and these indications are only going to expand. So definitely consider, even if you're not quite ready to accept TIL therapy, start having those conversations and just be ready for them coming up in the next few years.
You all really appreciate all your insights, and I can't agree more that it takes an absolute army of people to get this right. And then I think in our prep call, might have been you, Amanda, be prepared to go back and redo what you've defined as a workflow almost on every single patient basis until you can really come up with an ironed out process. So we do have a couple of minutes for questions, and I have been reading some of the great questions that have been coming through. I think just to start, just to clarify, and I know, Jen, you talked about this already, about the stress dose steroid, but how long after TIL should we wait before giving steroids?
No one knows. So yeah, this one's really, really tough. In general, it's kind of mimicking CAR T to where there might be an impact in kind of reducing the efficacy of those cells that you just infused. The nice thing about TILs versus CAR T, so we cannot really think of their toxicities the same, as that in TILs, all of these fevers, hypotension, et cetera, that looks like CRS, it's not CRS, it's the IL-2. So the IL-2's half-life is actually really quick. It's only in the body for its end half-life is about 60 to 90 minutes. So just holding off on the IL-2 is really going to be your most effective way to resolve those toxicities. Now, if we're talking a few days later, we're still not seeing any improvement, then that's when you do kind of unfortunately have to consider use of steroids, but really it's just supportive care. We personally have not had to intervene with any steroids yet in any of our patients. Just holding off on the IL-2, providing that supportive care until the body just can naturally improve, has been our management method. And it's just really honestly amazing what stopping the IL-2 can do.
Yeah, I can't agree more. I think that has been what we've learned over the course of time as well. Amanda, I saw you on mute.
I just want to say Jennifer brings a good point, because the side effects, even though they are overlapping with what we see in CRS with CAR T, we should know that tocilizumab is not part of the algorithm of supportive cares for TIL therapy. So that is something, as Jennifer said, really the main treatment is stopping IL-2 and initiating supportive cares for whatever organ is impacted. So pressor therapy, fluids, or diuretics, or whatever that might be, cardiac support. But tocilizumab does not really play a role within TIL therapy supportive cares. Steroids may or may not, kind of depending, as we've already discussed, the gray area, but just to be mindful of, tocilizumab is not part of this.
You bring up an excellent point. And you're right, we had lots of conversations when we were setting up our program about this, and it absolutely turns out that it's the management of the IL-2 that really is what we need to figure out. Just I guess, really quick, do any of your centers not do the LD chemo portion outpatient? Is anyone doing the LD chemo portion inpatient? I didn't confuse that.
Yep, we've been doing some of our patients inpatient based on kind of the single payer agreements with insurance, and some of the logistics upon what would be paid for if they were inpatient for a couple of days or outpatient and then admit for that cell day. Especially with right now, we're using continuous infusion mesna on our cyclophosphamide days, so there's just more logistics. Our goal, we do all our CAR T LD chemo outpatient, so that is our ultimate goal, is to push for that as well. But we're still in kind of our 10 or so patient numbers that we're just still working on those logistics. But right now we are doing the LD chemo not in the ICU, just on a regular hematology floor, and then moving them to the ICU on the TIL infusion day.
Yeah, our standard is to do it outpatient, but we get the luxury of being in a big city where traffic and logistics, so coming back and forth every single day for patients who live far away, is just not physically feasible. So we will make, exceptions for those patients who cannot manage the back and forth, and also patients, the lymphodepletion starts out with the high dose Cytoxan, and it is high dose Cytoxan. So anyone who's a little bit fragile or sensitive to prior chemotherapies, we do admit them as well for their portion of LD.
Well, thank you. Thank you all. I want to be really respectful of time. There are more questions, but unfortunately we're out of time. So I want to thank everyone for joining us today. Thanks to our presenters and to Dubai and ONS for your support in developing this great content.